The American College of Radiology,
Focused, forward.
together.
Well, good evening, everyone, and welcome. Thank you for joining us today for this important policy webinar titled Radvocacy in Action, a battle on two fronts, federal and state advocacy, hosted by the American College of Radiology's Radiology Advocacy Network, ACR-RAN for short, in collaboration with the California Radiology Society, or better known as the CRS. We're excited to bring together a distinguished panel of experts who have dedicated their careers to advancing health policy, legislative advocacy, and the future of radiology. I'm Dr. Mark Ye, a radiologist with Sierra Imaging Associates in Fresno, California. I'm a past president of CRS, where I currently serve on this executive committee. I also sit on the board for the ACRB and previously served on the board for RadPac. Today, I will be the moderator for this webinar. This session will give you a comprehensive overview of both federal and state level issues impacting our profession. We will begin with updates from the ACR, followed by a deep dive into California-specific developments led by CR's representatives. Now, let's go ahead and introduce our featured speakers. Speaking to federal issues will be Josh Cooper and Ashley Walton from the ACR. Josh Cooper is the Vice President of Government Affairs at the ACR. With over 30 years of experience in government relations and health policy, Josh has been a driving force behind key legislative initiatives that shape our profession. His expertise in advocacy, strategic communications, and coalition building has made him a respected leader in Washington. Alongside Josh is Ashley Walton, who is the Government Affairs Director at the ACR. Ashley has spent more than a decade focused on health policy advocacy, working tirelessly to ensure that physician voices are heard and that legislation supports high-quality patient care. Her commitment to advancing radiology policy is evident in her leadership and results. Together, Josh and Ashley will walk us through the latest federal developments, including legislative priorities, regulatory updates, and what they mean for radiologists across the country. Next slide. Next, we'll transition to the state level with insights from the CRS Government Affairs team. Ryan Spencer is the lead lobbyist for the CRS and also principal at RGS Consulting and Advocacy. Ryan brings 28 years of legislative and political experience, much of it rooted in the California state capitol. He has served under 3 assembly speakers and as a passionate advocate for the House of Medicine since 2017. Ryan has represented the CRS since 2024 and offers invaluable insight into state-level policy and strategy. Working with Ryan, we're honored to have Senator Kathleen Galgiani, who served in the House State Assembly and State Senate, representing the Central Valley from 2006 to 2020. In 2021, she was appointed by Governor Gavin Newsom to the statewide Gambling Control Commission. Her extensive experience includes roles with Governor Gray Davis, Insurance Commissioner John Garrett-Mendy, and other state leaders. Like Ryan, Kathleen has been advocating for the CRS since 2024, bringing her deep understanding of California's legislative landscape to our community. Finally, it is our distinct pleasure to have the CRS Government Affairs founder and chair, Dr. Stephen Wang, join us. Dr. Wang is a radiologist with the Southern California Permanente Medical Group in Bakersfield. He is an alternate delegate for the AMA's Integrated Physician Practice Section and also the current secretary for the CRS. Together, the CRS Government Affairs team will educate us about important statewide issues, both past and present, that significantly impact our profession, which will include a dive into current state legislative trends and regulatory challenges. We're grateful to all our speakers for sharing their time and expertise today. And with that, I'll turn this over to Josh and Ashley to begin the federal update.
Great. Thanks, Dr. Ye, very much. Ashley and I are very happy to be with you this evening. A little caveat before we begin, Ashley and Melody know that I have been having some technical issues, we'll just say, for the last several days and was with Verizon today for most of the day. So hopefully we got those things ironed out. I apologize in advance if I should drop, and Mel or Ashley, please let me know if I do drop so that I can go back and go over what may have been missed. Next slide, please. So oh, sorry. having those technical difficulties right now. We have been working on several issues so far with regard to the federal legislative aspects of the government. Some of what I'm going to talk to you about today are the One Big Beautiful Bill. Some may argue that title. Within that, physician payment, there were a few sections in that, as well as some obvious Medicaid issues. We'll be talking about that. Alongside of that, I'll also share with you what the CMS proposed rule had to say about physician payment. I'll also be then talking about amending PAMA, which is the Protecting Access to Medicare Act, something we've been working on for a little while and trying to get the PAMA AUC legislation that was passed back in 2014 finally implemented. I'll then hand it over to my colleague Ashley, who will talk about physician workforce, as well as the No Surprises Act, some updates on that. We'll be talking a little bit about AI in the regulatory space, as well as a slight mention at the end of the presentation when I talk about some of the state issues that we'll be focusing on. Next slide, please. So I'm sure as many of you who have followed along with regard to the reconciliation bill, which is basically what we've been dealing with for the last 3 to 4 months, the OBB or OBBB was passed through that reconciliation process, which is a process that allows budget-related legislation to pass with a simple majority. One of the key provisions that was included was a 2.5% increase in the Medicare physician fee schedule for calendar year 2026. We had thought we had gotten a deal prior to this bill passing that would have somewhat addressed long-term physician payment reform, but that was dashed kind of at the last minute, but we were pleased that Congress at least recognized that physicians needed a pay bump. Unfortunately, there will be no relief in 2025, which again signals to medical societies like the ACR that we're still going to have to work on getting a long-term care solution, and that for now we're going to have to still continue to work on short-term solutions. Next slide, please. So also contained in the Big Beautiful Bill were Medicaid provisions. These were more, if not the most controversial provisions coming out of the reconciliation bill. Medicaid from this bill sees substantial changes. These include new work requirements and cost-sharing measures. The federal provider tax is altered. States can no longer increase provider tax rates beyond what they had on July 4th, 2025. In those expansion states, the provider tax threshold will be reduced by 0.5% annually until it reaches a 3.5% floor. Though nursing homes and intermediate care facilities are exempt from that. State-directed payments, or SDPs, are also constrained. New SDPs must not exceed Medicare rates 100% in expansion states and 110% in non-expansion states. Existing SDPs will be phased down to these limits by 2032. Important to know, and I'm sure many of you have realized this, most of these changes are scheduled to take effect after the midterm elections in November of 2026, most likely in an effort, not that I'm a cynic or anything, to avoid immediate political fallout. And I believe that Ryan may go into this, the Medicaid issue a little bit more from a California specific point of view. Next slide, please. And somewhat just in a timing fashion, piggybacking off of the OBBB, was the publishing of the Medicare physician payment fee schedule proposed rule. That was in early July. CMS is proposing a slight increase in the conversion factor, in addition to the congressionally enacted 2.5% conversion factor increase for 2026. But also contained in the rule, which ACR will be, or the proposed rule, I should say, which ACR will be commenting on, is we will be commenting in favor of the collection of the prospective payment survey data, despite CMS's obvious doubt in the validity of physician-gathered data in general. ACR, and I imagine many other physician organizations, will be uh, strongly advocating that CMS continue using this data. ACR will also be commenting in opposition to the application of what CMS is proposing with regard to efficiency adjustments, not only in diagnostic radiology, but throughout medicine. ACR will be referencing the fact that, you know, often there are increasing numbers of images for radiologists to interpret, and that CMS needs to consider that fact with regard to efficiency adjustments, as well as the rapidly changing technology dynamic within radiology. And one of the bright notes, at least, is that after ACR's initial review of the facility-based proposed reductions, we believe that the diagnostic radiology is exempted, but unfortunately, in looking through, it does not appear that that is true for interventional radiology or radiation oncology. Next slide, please. So I'm going to now shift to one of the kind of legislative priorities that ACR will be pushing for by the end of the year, but hopefully not throughout the rest of this Congress, which goes on another 15 months. And that is amending PAMA AUC. I'm sure, as everybody knows, we were able to pass the AUC section of PAMA back in 2014, which the law required ordering physicians to consult appropriate use criteria prior to ordering advanced imaging studies for those beneficiaries who are in Medicare. We have gone back and forth with CMS since that time in 2014, now for going on 11 years. And thought we were close twice to getting it implemented, but CMS back in July of 23 for their 2024 calendar year rule basically put the PAMA AUC program on indefinite pause. But in doing so, they did recognize the value of the AUC program to improve utilization patterns. They believe that AUC would inform more efficient treatment plans. These are basically quotes from the proposed rule. And CMS would love it if this number were accurate. Basically believed that not implementing AUC was costing the federal government $700 million annually. So that would be $7 billion over a 10-year period, in which the Congressional Budget Office usually that is the amount of time or the window of time that they score budget items. So this would be a big saver. We did decide to go to the Moran Company, which is one of our consultants who models CBO estimates. Again, I'll mention, as much as we would love to have a $7 billion savings, they scored what is now the ROOT Act as saving still a nice amount, $2 billion over 10 years. And somewhat, if not more importantly, it would save Medicare beneficiaries $1.4 billion over that same amount of time. So our belief is that legislatively amending PAMA AUC would satisfy the concerns that CMS has and also allow us to simplify and provide substantial congressional savings. Next slide, please. So what we've done is taken the draft bill that the Moran Company took a look at, and we have now had it introduced. We actually got it introduced the day after our Hill Lobby Day back in May, and the bill is S1692. It is bipartisan legislation that was introduced by Senator Marsha Blackburn, a Republican from Tennessee, and Catherine Cortez Masto, a Democrat from Nevada. Both legislators sit on the Senate Finance Committee, which is the jurisdictional committee that will advance this bill, hopefully in the near future. We have two bipartisan co-sponsors, which have been added, Senator Jim Risch from Idaho and Senator Jackie Rosen from Nevada. There is another one that we added, Senator Rick Scott from Florida, uh, as well, right before the break. And throughout August, we have been meeting with Senate staffers to get ready to hopefully add some more co-sponsors uh, in September. On the House side, we are seeking to try and get what's referred to as a companion bill to S1692 introduced in the Energy and Commerce and Ways and Means committees. Those are the jurisdictional committees for Medicare in the House. So far, Diana Harshbarger, a Republican from Tennessee and who is on the Energy and Commerce Committee, and Congressman Blake Moore, a Republican from Utah, who's on the Ways and Means Committee, have agreed to introduce the bill. We are, again, like what we did in the Senate, we are seeking Democratic co-sponsors as well to introduce the House bill. Hopefully, we will be able to do that within the first couple of weeks of when they return, I guess on Tuesday now. Next slide, please. So what the ROOT Act does, it will eliminate the current real-time claims processing requirement in favor of an audit or review by CMS. It replaces that real-time claims process with an attestation process. So basically the ordering physician, in essence, by opening up the AUC software, the software automatically grabs all their information. So that is almost a self-attestation by opening up the AUC itself. It will collect ordering data, which will be subject to review and audit by CMS. Importantly for the radiologist, from the current legislation, it will remove the current quote penalty on radiologists who, if they were to submit claims without evidence of an ordering physician consulting AUC, then that claim might be subject to not being paid. We've also listened to the concerns of others in the physician community by providing a few other exemptions to AUC, the PAMA legislation. One would be ordering providers who participate in clinical trials would not be subject to having to consult AUC, and also those in small and rural practices, as defined by Medicare, would not have to consult AUC. And now I'm going to hand it over to my colleague, Ashley Walton, to talk about physician workforce and a couple other issues. Ashley?
Thank you, Josh. So this slide actually looks a little misleading in that the arrow is pointing up on the supply, but actually what it shows is that we are in need for a greater supply of physicians. So as it currently stands, the workload and the demand on radiologists is much more than the pipeline that we have coming through in terms of how many radiologists there are to do the interpretation for the number of tests that are being ordered. So there are several different solutions that ACR is backing that Congress can help enforce to address the workforce crisis. One goes back to what Josh was discussing, the implementing the PAMA established AUC programs. This will help address the physician shortage issue in terms of promoting appropriate imaging and reducing the overordering of low-value tests, and help manage just the overall workload on radiologists. Another issue would be addressing GME, or graduate medical education slots. So increasing the number of slots, especially for the different specialties, including radiology. There is legislation that ACR is supporting, the Physician Shortage Reduction Act, which would increase the number of GME slots by 14,000 over 7 years. Another way that Congress might address the workforce crisis is through creating smoother pathways for international medical graduates. There are a lot of stipulations on those that come to the U.S. and train and do their residency here. Typically, they have to return to their home countries after that training, and there is legislation known as the Conrad 30 program that would address that requirement by allowing those foreign medical graduates to stay here as long as they agree to practice in underserved areas for 3 years. Next slide, please. So now shifting focus, another key advocacy issue on top of those already discussed is the No Surprises Act. This is legislation that might sound familiar as it was passed way back in 2020, meant to protect patients from surprise medical bills. It established an independent dispute resolution process, or the IDR process, to ensure that physicians and insurers have a means to address payment disputes. Several rules followed the passage of that legislation issued by different government agencies, which predominantly governs the IDR process. This has not gone as smoothly as we would have hoped. It's amounted in lots of legal challenges. The Texas Medical Association has brought several lawsuits, and the ACR, along with other medical orgs, have joined as a friend of the court in those lawsuits. But the medical associations have fared pretty well in these challenges. I'm going to give a high level kind of introduction of what's happened in each of those lawsuits, but I won't go into too much detail. We refer to these as TMA 1, 2, 3, and 4 because there have been 4 lawsuits. TMA 1 really challenged the initial rules that were issued by the government agencies that would govern the IDR process, and that did come down in favor of the TMA. And then following that lawsuit, it basically required the government to reissue rules. So those were the rules that were then adopted and challenged in the next lawsuit, TMA 2. And the court ruled again in favor of the TMA, and that those regulations specifically were unlawful as it related to the QPA in terms of placing a heavier weight on the QPA in favor of any other factors that the arbiter has to consider when deciding these payment disputes as part of the IDR process. And then just to fast forward, we are in TMA 3 and still kind of pending a final decision on that one, so I'll come back to that. But TMA 4 dealt specifically with the IDR fee increase. These are the admin fees that are required to be paid in order to enter the IDR process. The initial fee was $50. The government then raised it to $350 at one point. The court ruled that this did violate the NSA, and then new rules came out and set that fee back to $115. So again, a win for the TMA and ACR. There were also challenges related to the batching process in terms of how claims are brought in the IDR process. That's kind of still pending in that we are waiting for new rules to be issued. There was a proposed rule at the beginning of last year. No final rule has been issued on that. So while the court did rule in favor related to batching, the government has yet to follow through and issue new rules on that matter. So back to TMA 3, it focused predominantly on the QPA, the qualified payment amount calculation, and how the government was utilizing that QPA calculation. So the court ruled partially in favor and partially not in terms of that decision. And so we did appeal, and that we had to ensure that the court, all of the judges were willing to rehear that case. And that was as of June 2025. And that was a positive result, and that they did agree to rehear that. So we are in the process of refiling briefings. And then again, we will have that reheard specifically on the issues of ghost rates and how they are used in calculating the QPA. So another issue as it relates to the No Surprises Act is the issue of non-payment. We've heard that often when physicians prevail in the IDR process, the insurers are still not paying. Legislation has been addressed in Congress that would excuse me, that would ensure that for non-payment, any party would be fined that would not pay within that 30 days after the IDR decision. So ACR is very supportive of this legislation. And that is known as the No Surprises Enforcement Act. And we have a bill in both the House and the Senate. Next slide, please. So shifting focus to research funding and the appropriations process, this is another issue that ACR follows closely. In terms of how the NIH budget is currently operating, it's operating under a continuing resolution. The appropriations process has not completely unfolded for the fiscal year yet. It's still underway. Each year, the president issues his own budget and has a request as it relates to NIH. For this budget, he did request a 40% reduction in NIH. That does not match what the research community wants. ACR, along with other organizations, are requesting 51.3 billion for the fiscal year 26, and this would be a 9% increase over 2025 funding levels. So very different from the president's budget, but the budget is actually controlled by Congress. They hold the power of the purse. So that's why the appropriations process is so important. We did have a hearing in the Senate on the Labor HHS Appropriations Committee back in July, and they maintained or closely maintained the FY25 funding for FY26, and that's a little over 48 billion. So not a complete reduction, but closely mirroring 2025. But the House appropriations process still has to go through its hearing, and that will probably be around September sometime, and then that has to be passed through Congress, and then we will have the actual NIH budget at that point in time. So you've probably seen through the news, there's been a lot of actions from the White House impacting the NIH. One of the big ones on top of that 40% reduction in NIH funding is that there have been facilities and administrative cuts. This is like a standard across the board 15% rate cut, and we've joined advocacy efforts to try and have a better outcome. This is still kind of going through the courts. We've seen restructuring of HHS, the Department of Health and Human Services, and really just an overall pushing of the Make America Healthy Again, and really all policies leading back to that policy. And then as part of ACR's effort, we've routinely participated in advocacy around NIH through different coalitions, including the Ad Hoc Group for Medical Research. We send multiple letters to Congress as it relates to research funding. We file radiology-specific testimony in front of the congressional appropriators. And it's through these efforts and some of our coalition efforts that, we're trying to increase NIH funding and ensure that those facilities and administrative cuts don't come to fruition. So that is NIH. Moving on to regulatory. Next slide, please. Some key activities that have taken place in the last several months. One key program under NIOSH, the National Institute for Occupational Health and Safety, is the B-Reader program. This is a surveillance program that provides screening. Basically, we saw a complete pause in April of both certification of those that read for the program and the co-worker specific program. ACR was very active in contacting Congress. This is an important program. We did see a positive result. Less than a month later, in May, we saw that NIOSH was restaffed after they had had some staff cuts, and then the programs were unpaused. So that was a good thing to see. And then in the VA specifically, the National Teleradiology Program was impacted with the across the board return to work mandate policy. And this would impact, those that are reading for multiple locations. So they may not be near a VA. You might have radiologists in the NTP program that, read for multiple VAs and do not actually have a physical center or physical workspace to go into. So we saw lots of issues with this policy. We worked with Congress and those who are on the Veteran Affairs Committee in Congress to address this issue, and we did get a exception. I know this impacted other specialties like psychiatry, I think neurology. So I think it's a case by case basis that they're granting these exceptions. So again, we see this as a really positive outcome. Next slide, please. So looking into the future, we're going to expect a shift from, the administration's efforts to reduce the workforce and looking, ahead at more policy specific. So some things will carry over from the Biden administration, like the HIPAA security rule, which specifically relates to cybersecurity, information blocking. You'll see the different points on this slide, lots of different things as it relates to AI and in the FDA, some policies in the Nuclear Regulatory Commission. But a big one that I think within the last couple of months just saw, or excuse me, last couple of weeks, the White House released the AI action plan. So it's not healthcare exclusive. There's a lot of different policies in there, but we see this to be a roadmap. It's focused on deregulation, innovation, American competitiveness. So these are kind of like the roadmap for what the administration and perhaps Congress might do on AI policy. So I will stop there and turn it over to my colleague. Josh, I think you're going to pick it back up.
Sorry about that. At least I didn't drop. So that's the one good thing about that. No, I wanted to share with everybody that some of the issues that Ashley talked about, the regulatory issues, are extremely important. They don't get as much ink, I should say, as a lot of the congressional issues do. But our folks on the regulatory side work extremely hard. And I think the B reader and the VA issues are just magnificent examples of your ACR advocacy team at work and turning that around and identifying the problem, and which was brought to our attention by our members, and our ability to contact those agencies, alert them to what's going on, what needs to be fixed, and actually those agencies being reactive and turning it around. So I think that is something that should be noted, especially. So I'm going to talk a little bit more about our state legislative efforts. We have some great people working on our state issues, Eugenia and Dylan. I'm going to first talk about our state scope of practice fund. That is something that a number of our states have taken advantage of. Basically, the ACR provides advocacy dollars for those states on various issues that can be used in a number of different formats, whether or not it's hiring a state lobbyist, doing some type of social media program that's has to do with whatever legislative or regulatory issues are going on in the state. It's been very successful and will continue, I'm sure, in the future. So if California is interested in that, please make sure to contact ACR. As far as scope goes, you can see on the slide the issues that we basically have been covering and monitoring and working with our states to kind of defend scope, if you will. So we'll continue to continue doing that. Next slide, please. So we're also kind of monitoring some prior authorization issues at the state level as well. You can see by the slide where we're tracking gold carding bills. The gold carding is a proposed approach to prior auth that aims to reduce administrative burdens and expedite care delivery. In theory, providers who consistently demonstrate adherence to evidence-based guidelines and achieve high prior authorization approval rates basically will hopefully skip those prior authorization processes in the future. The goals of gold carding are reduced administrative burden. Hopefully, physicians and their staff can spend less time on paperwork and the follow-ups, freeing up time for patient care. Also, it hopefully provides faster access to care as well. Next slide, please. And then finally, I just wanted to thank all those Californians who participated in our lobby day on Capitol Hill in the past May, and invite those who haven't had a chance to come to please do, and also participate in your state lobby days as well in Sacramento. We tried something new this year. We had our attendees wear white coats. It was a hit, both for our members and congressional staff. So I imagine we will be doing it again in the future. And with that, I thank you for your attention. And I will turn it over to Ryan and Kathleen.
Hello, everyone. Thank you guys very much for taking the time. Next slide. I'll first talk a little bit about CRS's advocacy here in Sacramento. I work with Kathleen Galgiani, who's been working with us, as we mentioned in the beginning, since 2024, lobbying by my side. Our office is located directly across the state capitol. It's walking distance legislature and key regulatory agencies. And I think it's very important for CRS to have boots on the ground here. You're busy in your practice, treating patients, getting them the results so they can improve their care, improve their health. But you don't have time to keep track of what's happening in Sacramento. That's what our job is. And so we keep track of what's happening both in the legislature and what's happening in the regulatory agencies to make sure whatever they're doing impacts you both positively, and whatever's happening that could impact you negatively, we have a voice to help change that. A lot of times we get that in real time and we try to respond in hours, just not days. We maintain active relationships with the DMHC, Department of Managed Healthcare, Department of Healthcare Services, Department of Insurance, and other key agencies. And through those relationships, we try to get early warning system flag any draft regulations or policy memos that might affect scope of practice, reimbursement rules, dose limits, or licensing. California, as you probably all know, is a national leader. What moves in Sacramento, the rest of the country watches. So radiology stakeholders nationwide look to us for regulatory trends. And so we have to be very mindful that what we do here doesn't just impact California, but also nationwide. Next slide, please. What I'd like to do is, like I mentioned, Kathleen and I have been representing you for just about a year and a half. We had a very good relationship with your previous lobbyists, your longtime lobbyists. who did some great work for you guys, and we look forward to continuing that work. One of the issues actually that he addressed in the next slide was already mentioned. Thank you. Was already mentioned early on the national level, and that has to do with balance billing, out-of-network patient billing. There was a bill back in 2012, AB 533, by Assemblymember, now Attorney General Bonta, and it simply tries to quell the impacts of balance billing. What balance billing is when a healthcare provider bills a patient for the difference between the provider's full charge and the amount the patient pays, as you know. But under AB 533, physicians would have been forced to accept Medicare rates for non-contracted services, which would have resulted in about a 35 to 45% revenue cut for many imaging practices. We made the at that time it was Bob Ackerman made the argument that network adequacy, not rate capping, is the solution. Insurers must build robust in-network radiology panels, especially in rural regions. So this was like a quick fix bill, but doesn't really fix the systemic problem, the fact that there's not enough providers in the network. So that bill was actually halted thanks to the work of the House of Medicine, including CRS. There was another bill that was introduced, which would have effectively done a very similar thing, AB 72. However, through negotiations and compromise, a more favorable result came out. And that essentially was this. It set reimbursements of out-of-network claims at 125% of Medicare with an independent appeal mechanism managed by the DMHC. So this would offset patient surprise bills while preserving practice viability, estimated to save California radiology groups about $30 million annually. We did this by framing the debate. And we stressed to legislators that healthy radiologist reimbursement underpins timely diagnosis and avoids patient care bottlenecks. Again, like I mentioned earlier, it's about rural and small practice impacts, and that's where we highlighted the most. Those are the folks who have been damaged the most if the previous bill went into effect, where margins are razor thin and surprise billing really drives patients away. So that was some good work done there. Next slide. Self-referral and lease arrangement reforms. CRS was a part of the original self-referral ban. In California, we have Stark Law, and this basically forbids physicians from referring imaging or radiation oncology service in which they have a financial interest. The whole purpose is to curb self-referral mills and protect patients from overutilization and kept diagnostic costs down. Put a prohibition on lease arrangements. It's basically closed a loophole where physicians lease space in imaging centers, then build technical fees indirectly. And it mandated that the centers build the technical component directly, ensuring transparent fee schedules and true organizational responsibility. In 2023, there was in-office exemption repeal. What that is we eliminated the carve-out that allowed self-referral for office-based imaging labs. According to the legislative analysis of the bill, it estimated about a 15% reduction in redundant advanced imaging, which resulted in a potential savings of $20 million per year. So some more good work. And next slide, please. We'll talk about something else that CRS is very much involved with, and that has to do with CT dose recording and radiation safety. It was the first in the nation in 2013. The first in the nation CT dose registry was created. This was SB 1237. It required all CT scanners to be embedded with DICOM dose indices into a statewide registry. This generates data for benchmarking, research, and targeted safety alerts, automized but traceable to facilities. Adverse event reporting. Any overexposed incident must be reported to CDPH with 24 hours, triggering immediate root cause analysis. And since this enactment of the bill in 2013, repeat overexposures in California imaging centers dropped by about 30%. It also strengthened oversight. So CDPH, the California Department of Public Health, uses registry data to prioritize on-site inspections where anomalies appear. So radiologists can see dose trends in their region, empowering peer-driven safety improvements. Moving on to mammography and advocacy access on the next slide. CRS has done a lot of work in this space. In 2015, the ACR accreditation was accepted. This eliminated California's duplicative state-level mammography certification and its $5,000 plus annual fee per site. So basically, if you're accredited by the ACR, that met the requirements for state law. This immediately opened the door for approximately about 200 smaller clinics to offer screening services. There was dense breast notification, SB 978 in 2013. This mandated that patient notices when dense tissue is identified with 6 months implantation grace period and liability immunity. This kind of brought up discussions on supplemental screening, MRI, or ultrasounds for higher risk women as well. Differential reimbursement under Every Woman Counts. This resulted in digital mammography set about 20% above analog, enabling faster adoption of 2D digital units and safety net programs. Another important issue we dealt with in mammography was Medi-Cal age, restoring the 40-year requirement. So right now it was, or before then it was at 50. So it's reverse approach shift from 50 screening under 2 weeks, restoring coverage for about 4,000 women annually who would otherwise lose early detection. Move on, next slide, please. Finally, I want to talk about personnel requirements for ionizing radiation users. So we have some legislation dealing with RT contrast and venipuncture legislation. This is AB 826. This authorized radiologic technologists to inject IV contrast after 16 hours of specialized training, allowing them to do that, help to alleviate some of the workload on the radiologists. We actually have a bill I'll talk about later on that actually enhances this. The successful legislation or law, I should say. I'll talk about it a little bit later. This built-in venipuncture certification requirements cut infiltration rates by about 40% and shave about 10 to 15 minutes off of each CT workflow. We also, of course, we had to push back on a few things, and we protected the fluoroscopy permit. We blocked AB 407 in 2019, which would have exempted non-radiologist MDs from requiring a fluoroscopy permit. And this course maintained uniform standards. About nearly 4,000 permit holders, holding physicians ensure safe procedural protocols. Next slide. Thank you. With the House of Medicine, one of the most important issues and something that is very unique to California is the ban on the corporate practice of medicine. This basically means that hospitals cannot formally employ, well, most hospitals cannot formally employ physicians. Since 1988, California's banned corporate practice, which prevents private equity or non-physician entities from owning medical practices. We successfully echoed CMA's concerns when bill surfaced, CMA, the California Medical Association, when bills surfaced to carve out hospital employment or allow private equity acquisitions. Moving on to the final issue of the past is the Medi-Cal advocacy and coverage, which I know our good folks at ACR already talked about. But up until this year, in the last couple of years, we've had great success trying to improve Medi-Cal rates for providers. We defended against a proposed rate cut of up to 10%, additional 10% in 2021, back when they were trying to figure out what to do during the COVID period, and we had a bit of a budget hit, which preserved critical revenue for safety net imaging. So that was very important. We engaged DHCS on fair MRI and PET add-on fees, led to creation of a new HCPCS code, adding about 15% above the base rate. We monitored the dual eligible transition to Medicare, preventing coverage gaps for over 500,000 Californians. We also backed Proposition 35. This proposition just passed last November, or sorry, 2 Novembers ago, last November, that was 2020, got to merge them together, 2024, that dedicated MCO tax revenue was potentially unlocking about $200 million specifically for Medi-Cal physician rates. So that's what CRS has done over the past decade and a half. So I want to talk a little bit about what's happening today. And, with that picture right now, as you see on your screen, that is actually the state capitol right now, where the legislature is housed as they rebuild the backside of the legislature, where the legislative offices, including the governor's office, is located, connected to the historic building. It's going to be about twice as big as it was before. So if you haven't been to Sacramento in a while, you want to come visit legislature, it's actually about 2 blocks away from the state capitol building, which gets a little bit hairy when we're trying to balance committee hearings, because some are located in the actual state capitol historic building, and then some are located in the swing space, what we call it, where the legislative offices are located. So next slide, please. So I talked a little bit about the Medi-Cal advocacy and coverage and the success we've had up until basically this year. Prior to the passage of HR1, Proposition 35 and the increases to physician reimbursement was already under attack. The budget was the California was suffering a budget deficit, and unfortunately the one issue that's often on the table is the healthcare funding. There are a lot of the strings that are tied to many other sources, and up until Prop 35, it was like the cash cow. Folks would go in that and they'd be able to make reductions, as we saw in the past. Every time there is a budget deficit, they immediately start to cut Medi-Cal rates, and there's a whole reason why Proposition 35 was passed to prevent that from happening. We thought we were able to protect ourselves, but the governor introduced his budget, and he did it in a way which is, I guess we'd say very sneaky, to be able to redefine what Proposition 35 really meant and ways to redirect that funding for other programs within Medi-Cal. We actually successfully fought and pushed back on that redirection of funds. And up until the passage of HR1, the increases, which was 87.5% of Medicare last year, this year is going to be about 87.5%, again, for more specialty services, including radiology, and hopefully in the years further, about 100% of Medicare. And that was the goal of Proposition 35. But then HR1, of course, was introduced, and that actually put a lot of that funding at risk. And as they mentioned, what HR1 did, it put a freeze on the provider tax, and this is the MCO tax is what funds Proposition 35. And so by putting a cap on the provider tax essentially stalls the funding for Proposition 35. Even if Proposition 35 revenues survive, the STPs, which we talked about earlier today, used to raise provider rates will be constrained to Medicare level ceilings, and so that make it even more difficult. So a lot of the meat has been taken out of Prop 35. It doesn't mean that we're going to stop fighting. It just makes things a heck of a lot more difficult. And we need to continue to find out ways to increase Medi-Cal rate, find ways to reinstate Prop 35 and keep that actually moving forward so that the MCO tax stays relevant. If it's not the MCO tax, we have to find another source to make sure that Medi-Cal provider rates stay sufficient. Otherwise, access to care is definitely going to suffer. If funding dries up and providers are paid less or drop out, patient access to care, especially for vulnerable or rural populations, could diminish significantly. So that's the state of Medi-Cal funding in California. It seems dire now, but we have some very strong advocates in Sacramento. California Medical Association and CRS have a very good working relationship, and we'll continue to work with them to find ways to improve the situation. Moving on, next slide, please. AB 460. AB 460 is a bill that's sponsored right now by the California Radiological Society. What it does, it updates the definition of direct supervision for radiologic procedures by allowing physicians to supervise radiological technologists via live audio and video when they're administering contrast for imaging. The current law requires that the supervised physician needs to be physically on site when this happens. But during the pandemic, the CMS authorized the supervising physician to be off-site. The problem, though, in California law was still pretty strict and said no, that the physician needed to be on-site. So we finally got a bill in this year that would remove that requirement and allow the physician to be able to be off-site with certain safety measures in place. And one of the main safety measures is making sure that someone is on-site that could be available to immediately respond in the event there is an adverse reaction to the contrast being administered. We are currently working with the Department of Public Health on drafting language, and I think we actually come to agreement so that they, because they're the ones enforcing it, would be not necessarily supportive, but would not necessarily oppose or encourage a veto of the bill. So we're in a pretty good spot there. So kind of to sum, right now, you need to be on site when a radiology technologist is administering contrast for imaging. this bill would allow you to be offsite and be able to supervise them through live audio remote, as long as somebody is on site to be able to assist in the event of an adverse reaction. So I've been kind of barreling through this whole presentation. I work very closely. I mentioned this with that I work closely with Kathleen, but Dr. Steve Wang is the chair of CRS's GR committee, and nothing I do, particularly with this bill or any other bill, I do without consulting with Dr. Wang. He's been an essential component of CRS and a strong advocate for the association. This bill wouldn't be possible without his input, so I want to give him an opportunity to weigh in if he has anything else to add. Dr. Wang?
Oh, same to you, Ryan. This couldn't be possible without you either. Now, this bill is actually, as I said, as you've said, that it aligns with federal regulations, and in the 2026 CMS proposed rule, they are going to make the remote supervision for virtual direct supervision permanent. And so if this passes this year, it will come just in time as federal rules come into place as permanent. And as we've mentioned before, this does require that some people other than technologists, or some people who have a little higher qualification than just a technologist, would have to be on site in order for this to occur. That being said, this does give you a little bit more flexibility than what you had before, and it will align with federal standards.
Excellent. Thank you, Dr. Wang. Kathleen, do you have anything to add?
Yes, I did. Ryan, you referenced AB 533 earlier, and I just wanted to say that this is a perfect example of why your advocacy is so important. I had a front row seat at the time because I was in the Senate. It was one of the most highly debated measures that we heard that year. And ultimately, the outcome was not partisan. I was one of 5 Democrats and 5 Republicans that joined you in opposing the measure because your advocacy team drove home the point that tying the reimbursement and balanced billing to Medicare was too low. And so again, your work set the stage for the bill to be held on the inactive file on the Assembly side. And it's just one more example of why everything that you do in Sacramento is critically important.
Thanks, Kathleen.
Thank you.
So I want to touch upon, before we go to questions, there's 2 more bills that kind of highlight some of the other issues that we're working on, and they all involve artificial intelligence. Thank you. So I will say that most of the bills that are introduced, they start off a little reaching in terms of getting little ahead of themselves in terms of regulating AI. We all know it's a new tool that can be useful, but there are probably some ways that it could be regulated, but needs to be regulated responsibly. The issue we come up against is you get so many bills introduced at the state level, everybody wants to be a part of the solution, and it becomes just a mess. There are some good bills dealing with AI that we actually support. I want to talk about one of those right now, and that's AB 489. AB 489 by Assemblyman Banta, the chair of the Health Committee. This addresses the growing safety and security risks that are posed by AI chatbots that falsely claim that they're licensed medical professionals. Existing law already prohibits false advertising and misrepresentation of qualifications. This bill just makes it clear that these protections apply equally to AI and generative AI-enabled systems or devices. It authorizes oversight entities to take action against developers and deployers who are engaged in these prohibited acts. What makes this bill worthy of our support, it has a targeted regulatory scope, not overreaching, not too broad that some of these other bills do. It narrows the oversight to high-risk AI functions, avoiding an all-encompassing definition that would capture routine software updates, prevents like a one-size-fits-none problem, and keeps innovation pipelines moving. It streamlines compliance. It prevents local or agency-specific rules by aligning with FDI's SAMD guidance. Radiology practices can complete a single annual self-attestation instead of multiple jurisdictional audits. There are clinically qualified audits. What this does, it mandates any third-party review be conducted by entities accredited in the radiological safety or in medical physics, not just any third-party review, and protects providers from erroneous flags by lay auditors and ensures clinical context guides every assessment. And finally, it minimizes cost burdens. It avoids duplicative review cycles, saving about $50,000 per mid-sized practice each year, and frees up resources to invest in AI training programs rather than compliance paperwork. So the narrow focus of this bill, which is also sponsored, I should say, by the California Medical Association, in addition to being supported by CRS, is one good example of somebody who came to the folks impacted and said, well, how can I make this better? An example of the bad, next slide, please. AB 1018, which I spent a good part of my day talking to offices about. And this is probably this is the best example of a problematic AI bill. AB 1018 regulates the use of automated decision systems, ADS, that make or facilitate what we call consequential decisions, which I would say is pretty much any decision that is made by a physician, and does this by impacting individuals' legal rights or access to opportunities, services, or resources. It requires developers to conduct performance evaluations, documenting system design, expected use, and potentially disparate impacts, and requires deployers to notify affected individuals, provide opt-out and correction rights, and allows appeal final decisions. When you say it just like that, it doesn't seem like it's that bad of a approach. Like it just trying to put some structure together to regulate ADS. The problem is how it goes about it. Overly broad AI definitions, it casts a wide net that would ensnare basic decision support tools and routine updates under a quote AI medical device regulation. Every software patch could trigger a full compliance audit, and that's definitely not what we want to have happen. It has unregulated third-party audits, requires annual reviews by private firms with no radiology or medical physics credentials, unlike 489, and a risk in inappropriate test failures and arbitrary penalty triggers. It also imposes heavy administrative and financial costs. It proposes a sliding scale penalties up to $25,000 per nonconformance event, an existential threat to small and rural practices for sure. Mandatory documentation, reporting, and data retention requirements could add over 200 staff hours per year. This would basically have a chilling effect on innovation. Radiology departments may pause or abandon AI pilots rather than navigate burdensome red tape. I mean, if it becomes too much of a problem to use this AI tool, which we know benefits our patients, but if it's just too much of a hassle and it pulls your time away from actually doing your job, it may be not, like the juice may not be worth the squeeze. So ultimately, this slows the very accuracy and timeliness gains that AI promises for patient care. And we really can't let that happen. And so we've been talking to numerous offices, and we continue to talk to them until the end of session on September 12th. Hopefully the bill doesn't go that far. So that is what I have for you guys. So I really appreciate you taking the time on this evening. And I think we will welcome any questions.
Thank you, panelists, for your excellent presentations. We're at the top of the hour, so we're running a little bit over time, but I think we have a little time for questions if the panelists can or are willing to stay around. We have one question from Dr. Lightfoot in the Q&A box. He says that the Medicare cuts expected for 2026 after the midterms will be substantial. Our hospital is already girding and cost containing in expectation of those reductions in both reimbursement and in service volume and case counts. Do you have any advice for hospital-based radiology groups whose hospitals are planning for, in essence, downsizing consequent to Medi-Cal revenue reductions? I guess either Josh or Ryan or both of you can respond.
Well, I'll answer very quickly. I think Dr. Lightfoot, we're constantly analyzing, and I think we're going to have to work with each state to kind of figure out what the impact will be. And obviously, yeah, you guys are going to have to, across the nation, everybody is going to have to figure out what, if any, cost-cutting measures are going to have to make up for some of these cuts. I mean, I will put in a little bit of optimism. I don't think that it'll happen. I mean, the one thing delaying the actual cuts into 27 is there may be time to try and mollify them a little bit, depending on what happens in the meantime with other hospitals across the nation cutting back. And if that impact is severe, I would hope and imagine that possibly Congress might revisit this.
Okay. We have a question from Dr. Liu, and this is for the state side.
Yeah.
Is AB 35 ultimately not going to give us the increase in Medi-Cal reimbursements we were expecting?
It's too early to tell, to be honest. I mean, I painted a picture of the problems that Prop 35 has encountered with the passage of HR 1. Obviously, we also face the problems that the governor's budget posed, but we got through that. It's too soon to tell. I know that CMA is working through this right now. I've been actually talked to get an update, and I was hoping to have it before tonight, but I was not able to get it. But they are right now. I will say that the hope is that these increases will continue to move forward, but I do know with the passage of HR 1, it makes things a heck of a lot more difficult. So we'd have to find another source of revenue if the MCO tax goes away. And so right now it's too soon to tell. But yeah, it's definitely we're in a different environment than we were in December of last year.
Okay, just so everybody knows, if you want to ask your question live, I think we can unmute you. Am I correct on that, Melody? You can raise your hand, we can unmute you. I have one quick question for the federal folks. Do you expect any movement in Congress for a significant healthcare bill this year?
Well, I think Congress will have to address what are called Medicare extenders, which is kind of an annual event. So there will be some type of healthcare package. Will there be a massive healthcare bill that will include any type of long-term physician payment reform? I don't think so. I think we're going to have to see what happens in September. We've got a number of appropriations that they're going to have to pass. We most likely will end up with a continuing resolution at the end of the month. We don't know how long that will be. And I think how well these guys play with each other in the next 30 days will probably dictate what they'll consider to do by the end of the year, including healthcare.
Thanks. And one last question, if nobody else has any other questions for CRS folks. Can you talk about the next steps for these bills you mentioned real quickly?
Sure. All three of the bills that I mentioned are all assembly bills. They're currently in what's called the Assembly Appropriations Committee. The Assembly Appropriations Committee is the fiscal arm of the state legislature, so they analyze the cost that each bill may have to the state. And with AB 460, for example, the costs aren't that great, but it was just enough to be put what's on called the suspense file. And so any bill that costs more than $50,000, which are most of them, get put on the suspense file. And this Friday, we're going to learn if those bills are actually going to move forward. And so all these bills, AB 1018, AB 49, AB 460, those all are on what's called that suspense file, where they're going to look at everything, all the bills that cost more than $50,000, and they'll decide which ones move forward. A lot of the bills, the outcomes for these bills really determine on the discussions you have with the department, because that's where the costs are. And so I feel pretty good about 460 getting off, because our conversations with them and amendments they're going to take have been very positive to help lower the cost with the department, so they don't have to impose so many regulations. We're hoping, for example, that 1018 costs so much that it won't move off of suspense and effectively die in committee. So if any of those bills get off of suspense, and let's just use 460 as an example, since that's our bill, it will go to the Senate floor. It needs to pass out of the Senate floor and then go to the Assembly for a vote on whatever amendments were done to it before September 12th. So basically, this Friday we'll know if the bill is moving forward, and then when it gets out, then it has till September 12th to pass both the Senate and again in the Assembly, and then goes to the governor. The governor then has until October 12th to sign or veto the bill. Once it gets signed, it'll go into effect on January 1st, 2026, and that's when the impacts of the bill, the ability to be able to supervise radiology technologists would go into effect.
Thanks, Ryan. Looks like we have a couple raised hands. Dr. Olson, I think you're unmuted.
Yes, thank you, Dr. Ye. I don't have a question. I just wanted to make a comment for those that are listening, especially if you have not been terribly involved in the CRS before. If you're a member but you haven't had the chance to get involved, first of all, welcome. I hope you do. But what I hope you take away from this wonderful webinar that both the ACR and the CRS put together is all the things that your dues are doing for you. You know, people complain about the cost of dues and being a member of an association, but if we don't have members at the ACR and the CRS level, we can't have our teams doing the kind of things that you're hearing about tonight. And, you know, Ryan's presentation with the last 15 years of wins for radiologists in this state is really something you ought to think about. This is what your dues are doing, and you're spending less than a cup of coffee a day to make this stuff happen. And if you have partners that have chosen not to be members of the ACR and the CRS, I really urge you to advocate and get your partners involved, at least get them to join and pay dues. We need the revenue to be able to do these things, and I just wanted to get that out there. So thank you, Mark, and everyone for putting this great thing together.
Thank you, Mark. I believe Dr. Liu also has his hand up. Can we unmute him, please?
Oh, hi. Thanks, Dr. Gay. And I totally agree with those comments, Dr. Olson. Those are very, very true. This is a question for both the federal and state. So, Ryan, you had told us about AB 72, which was California's version of kind of like the No Surprises Act. And then we have the federal No Surprises Act that Josh had told us about. So in California, which of these laws actually take precedence